Welcome to Breast Cancer, Risk Assessment Tools, and Screening and Diagnostic Choices, presented by Jeanette Kennedy, Jane Nelson, and Jackie Stanzel. There are 4 learning objectives for this presentation. Participants will be able to choose 3 acceptable risk screening assessment tools used for the identification of breast cancer risk. They will be able to report an increase in knowledge of appropriate diagnostic studies to order based on the patient's lifetime risk of breast cancer and history and physical, and will choose 2 appropriate diagnostic studies used to diagnose breast cancer, as well as report an increase in knowledge about the importance of communication between diagnosing providers to improve continuity of diagnostic interpretation by the end of the education presentation. Breast cancer is the most common cancer found in women worldwide. It's the most common cause of death among women ages 40 to 44 and is the second leading cause of death among all other women behind lung cancer. Tumors can grow for upwards of 10 years before being detected. Not all breast cancers grow at a slow pace, though. Over 50% of breast cancers begin growing in the milk ducts, and about 15% begin in the lobules. It is estimated that there will be 286,600 new cases of invasive breast cancer in women, 2,670 new cases of invasive breast cancer in men, 41,760 breast cancer deaths in women, and 500 breast cancer deaths in men in 2019. We chose this topic because breast cancer impacts 1 in 8 women in their lifetime. Women deserve prompt and accurate diagnosis with reassurance that they have not been misdiagnosed. Providers need to communicate and agree on findings of diagnostic studies. If providers do not communicate accurately or in a timely manner, it can delay diagnosis and treatment of breast cancer. This can be detrimental, especially if the cancer is in aggressive form. Women also need providers to be aware of the psychosocial needs they may have at different stages of their cancer journey. Throughout this presentation, we will address the pathophysiology of breast cancer, the etiology and risk factors, breast cancer diagnostics, recommended treatment patterns, and the psychosocial needs of the patient at each stage.
The patient case study presented here will be revisited throughout the presentation. Throughout this presentation, we will use a case study to evaluate the information being presented. We will refer back to this case study at some point during each section. You are a provider in a clinic. A 46-year-old Caucasian patient presents to clinic and reports finding a lump to the upper outer quadrant of her left breast. It was an incidental finding during a monthly self-breast examination. The lump is painless and is the size of a quarter. There is no history of cancer in the patient or her family that she is aware of. The patient has hyperlipidemia and depression. She had a hysterectomy in 2014 and has been on combined hormone replacement therapy for 3 years. Her current medications include atorvastatin 5 milligrams PO on Monday, Wednesday, and Friday, Wellbutrin 150 milligrams twice a day, and vitamin D3 5,000 international units daily. The patient has no family history of breast, uterine, or ovarian cancer to her knowledge. She is adopted by her father and does not have any knowledge of her biological father's family history. She has no personal history of any cancer. She started menstruating at age 13. She is gravidia 3, para 3, with her first pregnancy at age 21. She breastfed all 3 children. She had a hysterectomy at age 42 and went through early menopause at age 43. Weight 162, BMI 26.1. She was a former smoker, quit in 1997. Alcohol use average 1 to 3 times per week, 2 to 3 glasses of wine or beer, and exercises 1 to 2 days a week.
Based on your current knowledge, what risk management tool would you use to assess this patient's lifetime risk of breast cancer? What screening and diagnostic approaches would you use for this patient? What are the patient's psychosocial needs when she presents to the clinic for this initial visit? We will give you 45 seconds to answer the above questions, then we will discuss them as we go through each section. Let's see if you get to learn something new. The following section will be a brief discussion of the etiology and incidence of breast cancer. The overall incidence of breast cancer is 44 in 100,000 women under the age of 50. This increases to 345 in 100,000 women over the age of 50. Breast cancer actually has a bimodal incidence pattern, which means it peaks at 2 different ages. The first around approximately age 50 and the second around approximately age 70. The different subtypes of breast cancer may reflect the bimodal pattern based on age and hormonal influences. The lifetime risk for men is 1 out of 883. New cases of breast cancer are about the same for African American and Caucasian women. However, African American women under age 45 have a higher incidence of breast cancer than Caucasian women. African American women have a higher mortality rate related to breast cancer than Caucasians. African American and Hispanic Latino women are more likely than Caucasians to be diagnosed with late-stage breast cancers. They also tend to have larger tumors than Caucasian women. Breast cancer incidence is lower among Asian and Pacific Islander and Native American women than for Caucasian and African American women. Women of Ashkenazi Jewish descent have a higher incidence of breast cancer. This population has a high prevalence of the BRCA1 and BRCA2 genetic mutations. The BRCA genetic mutation is actually very rare. In the U.S. general population, the prevalence for being a carrier of one of the mutations is only 1 in 400. However, the prevalence of being a carrier in the Ashkenazi Jewish population is 1 in 40. Men can also carry one or both of the mutations, and it does increase their risk for breast cancer. The risk for developing breast cancer increases 55 to 65% for those with the BRCA1 mutation and 45% for those with the BRCA2 mutation. This section discusses the modifiable and non-modifiable risk factors for breast cancer. When educating patients, it's important to discuss the many different factors. Many patients who present with either abnormal mammography findings or a palpable nodule have probably already consulted Dr. Google. There are several risk factors outside of family history and genetic mutations that rely on several variables around environmental exposures and lifestyle choices. These variables are age, gender, age of menarche, age of first pregnancy, history of breastfeeding, exercise, lifestyle, alcohol consumption, radiation exposure, and use of hormone replacement therapy. At times, patients may not show any concern at all due to the thinking that breast cancer is more of a genetically linked disease. This is important as only 7% of all diagnosed breast cancers are related to BRCA1 or BRCA2 genetic mutations, and the incidence of other familial linked breast cancers are even less. Non-modifiable risk factors are ones that you cannot change. These include age over 50, early menarche, late menopause, genetic mutations such as BRCA1 and 2, family history, and radiation exposure. Research has shown that certain reproductive risk factors, such as nulliparity and increased time frame between menarche and age of first birth, are associated with increased risk of HER2 positive breast cancers. Family history of breast, ovarian, fallopian tube, primary peritoneal, prostate, and pancreatic cancers have been shown to be related to increased risk of breast cancer based on the type of germline mutation. Dense breast tissue has shown a moderate increase in risk, and atypical ductal or lobular hyperplasia increases risk by fourfold. Ionizing radiation to the chest in treatment of non-Hodgkin's lymphoma between the ages of 10 and 30 have an increased risk, with girls ages 10 to 14 being at the highest risk due to the development of breast tissue at this time. Modifiable risk factors are ones that you can change. They include lifestyle choices like weight control, diet, level of exercise, alcohol intake, age of first pregnancy, total number of pregnancies, history of breastfeeding, and prolonged use of HRT. Advanced maternal age of first birth, older age of menopause, and younger age of menarche are less consistently reported as associated variables to increased risk of HER2 positive breast cancer. Parity is associated with a decrease in the risk of HER2 positive breast cancers. Breastfeeding has been shown to be associated with a decreased risk of HER2 positive and triple negative breast cancers. Postmenopausal women using combined HRTs have been found to have a higher risk of breast cancer. This section will discuss the pathophysiology of breast cancer and the different types. Most breast cancers are initially hormone dependent, either estrogen receptor positive or progesterone receptor positive. Estrogens have a critical role in the development of these cancers because estrogens regulate processes that are crucial for cellular functions by regulating activities of key molecules. Steroid hormones, such as estrogen, have been found to regulate cytoplasmic cascades and non-genomic effects. In the many hormone-dependent breast cancers, estrogens contribute to the development of cancer cells, as most require estrogen for growth. HRTs cause an increased risk of breast cancer. Women taking combined hormone replacement therapies tend to have an increased breast density on mammogram compared to those on just estrogen hormone replacement therapy. Women taking estrogen-only hormone replacement therapy have a 2% increased risk of breast cancer per year, with a 10% increased risk after 5 years, although that risk increases to 30% in women with a BMI of 20. Mammographic density of the breast is the radiologic appearance of the breast tissue variation and is associated with a 4 to 6-fold increased risk of breast cancer if density is seen in 60 to 75% or more of the breast tissue. There is a strong correlation of mammography density with other risk factors such as BMI and age, but it is also an independent risk factor for breast cancer itself. Histologic studies of the breast have shown that specimens of mammographic dense tissue have epithelial and stromal proliferation. Cancer occurs when cells' growth exceeds cell death, causing cells to grow out of control. These cells can form cancerous tumors. Studies of mammary epithelial cells have found that hypermethylation of P16INK4A creates a premalignant lesion. These are called variant HMECs and are characterized by a lack of P16INK4A activity, which allows proliferation for long periods of time with disappearing telomere sequences, which leads to telomere dysfunction and chromosomal abnormalities. These abnormalities can be noted in the earliest lesions of breast cancer. Ductal carcinoma in situ, or DCIS, occurs when a proliferative group of cells have not grown into the surrounding tissue but have remained in place. They usually are found in the milk ducts. DCIS begins as a non-invasive cancer because the cells have not spread, but if it's not treated promptly, the cells can spread, becoming invasive over time. DCIS can be divided into 5 subtypes of classifications. They are papillary, micropapillary, cribiform, solid, and comedo, although the first 4 are often grouped together and termed non-comedo type. In a single biopsy, comedo and non-comedo type may both be found. Lobular carcinoma in situ, or LCIS, occurs when cells occur in a non-cohesive cluster, mostly in the lobules. LCIS is uncommon and tends to be an incidental finding. It is often found before menopause and tends to be bilateral. Invasive carcinoma develops in 25 to 35% of women with LCIS. Invasive breast cancer occurs when the cells spread beyond the originating tissue into its surrounding tissues. This can include other areas of the breast or axillary lymph nodes. It is common to be found in the upper outer quadrant of the breast. Metastatic breast cancer occurs when the cancerous cells spread beyond the breast and axillary lymph nodes into other areas of the body. The most common places for the cancer to spread include the brain, bones, liver, and lungs. There are many types of breast cancer. We will briefly go over the different types. There are 2 types of carcinoma of mammary ducts, papillary and intraductal. Papillary carcinoma of the mammary ducts appears as well-delineated groups of cystic masses in several different areas. Oftentimes, hemorrhages may present and it can involve the skin. The common age group for this type of cancer is 40 to 60-year-old women. Intraductal carcinoma of the mammary ducts are well-differentiated tumors within the ducts that rarely involve the skin. There is often evidence of inflammation. The next type of breast cancer is infiltrating carcinoma. There are several types of infiltrating carcinoma, including ductal carcinoma, mucinous carcinoma, medullary carcinoma, tubular carcinoma, adenoid cystic carcinoma, metaplastic carcinoma, and squamous cell carcinoma. Ductal carcinoma is characterized as a firm fibrous mass that may glisten gray with chalky streaks. It can appear to look like a mixture of patterns, can cause nipple discharge, and it accounts for 79% of all breast cancer. Mucinous carcinoma is usually a large encapsulated glistening tumor that varies in color and tends to occur in older women. Medullary carcinoma also tends to be encapsulated and can grow to be 7 to 8 centimeters in diameter, but tends to occur in women 50 years of age and older. Tubular carcinoma is well differentiated with stroma in the center of the mass and has been previously associated with non-infiltrating ductal carcinoma, although the occurrence, which tends to be in women over 50 years of age, is rare. Adenoid cystic carcinoma is very rare and tends to be a painless mass that is found to arise from the areola and nipple area. Metaplastic carcinoma is a mix of tumors and osteogenic sarcomas that involves cartilage or bone. Lastly, squamous cell carcinoma originates in the ductal epithelium and occurs most often in African Americans. Carcinoma of mammary lobules will be discussed in this slide. There are 4 types: lobular carcinoma in situ, or LCIS, infiltrating lobular carcinoma, Paget's disease, and inflammatory carcinoma. Lobular carcinoma in situ is often found in people with fibrocystic disease and is localized to the upper breast quadrants. It often occurs in the mid-40s to early 50s. Infiltrating lobular carcinoma infiltrates from the duct and causes a firm mass with streaks that are chalky. Paget's disease is characterized by eczema appearance of the nipple and areola region with poorly circumscribed cancer under the nipple. Inflammatory carcinoma is very rare. When it does occur, it's fairly diffuse throughout the breast tissue with edema overlying the skin. The last category is sarcoma of the breast. There are two types of sarcoma. These include cytosarcoma phyllodes and fibrosarcoma. Cytosarcoma phyllodes is usually very large in diameter, can rupture through the skin, occurs across a wide range, and rarely metastasizes to the lymph nodes. Fibrosarcoma usually does not involve the nipple or the skin. It is firm, well circumscribed, and is very rare. This section touches on the breast cancer staging system. It is important to be informed how breast cancer is staged because patients and families will have many questions regarding staging and treatment. Breast cancer is staged using the tumor node metastasis, or TMN staging system. The TNM staging system looks at the size of the primary tumor, the status of the lymph nodes, and the metastasis status. The T stage is categorized from T1 to T4. The N stage is determined by the lymph node involvement and includes internal mammary, supraclavicular, and axillary lymph nodes, and the M stage assesses metastasis status. Breast cancer staging is done primarily by the specialists and not the primary care provider. This is an example of the TNM staging system. This section will discuss several different risk assessment tools, their benefits and limitations, and compare their similarities and differences. It will also discuss which tools are recommended over others. There are several tools that have been developed to estimate a patient's risk of developing breast cancer. With the recommendation to individual breast cancer assessment and screening, these estimations can help guide a provider's discussion of evidence-based management with their patient, from lifestyle modification to risk-reducing bilateral mastectomy and bilateral salpingo oophorectomy, such as what Angelina Jolie did. Some of these tools only take into account family history. Some consider the patient's reproductive history and family history, while others also take into account lifestyle and use of hormone replacement therapy usage. The BICRAT or Gale model is a breast cancer risk assessment tool that estimates patients' chance of developing invasive breast cancer over the next 5 years up to the age of 90. It provides a 5-year risk assessment and lifetime risk assessment. It includes personal medical and reproductive history, as well as first-degree relative history of breast cancer. It also takes into account if the patient has ever had a history of biopsies and results of hyperplasia findings on those biopsies. The benefits of the BICRAT or Gale model are that it takes into account patient history of ductal carcinoma in situ or lobular carcinoma in situ, patient age, ethnicity, age of menarche and of first pregnancy, the number of breast biopsies the patient has had, and any atypical results of those biopsies. While it does account for the patient's personal reproductive history, it is minimal. The BICRAT tool does have some limitations. It does not take into account breast tissue density, number of pregnancies, age of menopause, history of breastfeeding, and use of HRTs. There is limited data for the Native American and Alaska Native populations. Therefore, there is the risk of underestimation within those populations. This tool may also underestimate African American women with a history of breast biopsy and Hispanic women who were not born in the U.S. The BICRAT also has poor accuracy in the presence of BRCA genes, patients with a history of carcinoma in situ or invasive breast cancers, and Li-Fraumeni syndrome, which predisposes those patients towards development of breast cancer. The Tyrer-Cuzick or IBIS model is considered to have the most comprehensive set of variables and is the most sensitive of all the models in estimating the risk for breast cancer. This model is the only one that not only accounts for risk factors outside of genetics, but also includes both extensive personal, reproductive, and family history. It incorporates the presence of the BRCA gene into the assessment as well. Keep in mind, there are no real clear-cut evidence-based guidelines that point to a specific cluster of risk factors that necessitate an in-depth model like the Tyrer-Cuzick. The benefits of the IBIS is that it does take into account lifestyle and reproductive history, as well as genetic factors. Since the IBIS is one of the more in-depth risk assessment models in use at this time, it is considered to be the most sensitive of the risk models available. The limitations of the IBIS are that it does not take into account history of biopsies, including number of and results, or breast density as variables. While non-genetic risk factors are related to incidence of breast cancer in the general population, they are considered weak variables. There are no assessments or scoring for reproductive history or lifestyle at all. The breast cancer risk questionnaire is recommended to be administered at regular intervals as a person's risk changes over time. It should be started at age 18 and continue through to age 74. The first section is related to the patient's personal history of cancer. The second section of the BCRQ relates to family history. The family history questions with this tool are extensive in nature. You can see that the history includes second-generation family members, including males. However, it does not take into consideration age of menarche, age and number of pregnancies, age of menopause, or use of HRTs. It relies solely on patient and family history of breast or ovarian cancer only. This table describes how to score and interpret the responses to the risk assessment questions of the BCRQ. This is a visual of the screening recommendation based on the BCRQ score. Risk factors other than those addressed in the risk assessment questionnaire, such as breast density or age of menopause, may exist, but the developers of this tool felt that there is insufficient evidence to support including them at this time. This was a guideline that was adapted in 2015 to 2016 from the U.S. Preventative Services Task Force and American Cancer Society guidelines. The benefits of the BRCQ include looking at the patient's personal incidence of breast cancer before age 50, ovarian cancer at any age, and presence of genetic mutations. History of chest radiation for non-Hodgkin's lymphoma between ages 10 and 30, history of breast biopsies with hyperplastic changes, and includes a very in-depth family history of breast or ovarian cancer, including incidence of male breast cancer. The BRCQ also recommends that risk assessments be performed at regular intervals in recognition that risk scores change over time. The limitations to the BCRQ are that it does not account for the patient's personal reproductive history, including use of HRTs or lifestyle risk factors. It relies solely on age, history of related cancers, genetic mutations, and familial links. The Breast Cancer and Ovarian Disease Incidence and Carrier Estimation Tool, or BOA-DITSIA, is used to estimate the chance of carrying genetic mutations and increasing risk for familial breast and ovarian cancer. It computes the probabilities of a person carrying genetic mutations that increases their risk for breast cancer. These include family histories of breast, ovarian, fallopian, primary peritoneal, prostate, and pancreatic cancer. The Boadicea is much more comprehensive in identification of patients with familial variables that may have otherwise been missed. This leads to individualized, informed decision making on preventative and screening approaches. Approximately 7% of breast cancers are related to BRCA1 or BRCA2 mutations. The percentage is even smaller when looking at familial history outside of the BRCA1 and BRCA2 mutations. It is susceptible to underestimation of risk based on other multifactorial variables that have been shown to increase risk outside of genetic links. This includes personal history, reproductive history, and lifestyle variables. The iPrevent is an online tool that walks women through questions regarding their age, reproductive health, lifestyle, and family history. The reproductive history question includes age of first child born and how many children they have, age at menopause, and use of HRT. Based on answers, iPrevent selects one of two validated breast risk cancer models, either the IBIS or the Boadicea. Based on results, iPrevent offers recommendations on evidence-based guidelines, screenings, and management suggestions. The results categorizes the woman's lifetime risk into average, or 1.5 times population risk, moderately, or 1.5 to 3 times population risk, or high, greater than 3 times population risk. The iPrevent risk management options are individualized to each category. Average risk recommends biennial mammogram and no need for risk-reducing medication or risk-reducing surgery. Moderately increased risk recommends annual mammograms, yes to risk-reducing medications such as tamoxifen, raloxifene, anastrozole, or exemestane based on pre- or postmenopausal, and no need for risk-reducing surgery. High-risk recommendations are annual mammogram and MRI, yes to risk-reducing medications, and yes to risk-reducing surgery. Lifestyle modifications are recommended for all categories. The benefits to the iPrevent tool are that it's easy to access online and it's user-friendly. It directs the user to the specific tool after reproductive history and family history questions have been answered. The tool has been validated through research in regards to its link to the IBIS and the Boadicea. The limitations are that it only connects to two specific risk assessment tools, which are very different from each other. The IBIS is very inclusive to lifestyle choices, thorough reproductive history, and thorough family history, whereas the Boadicea only includes family history. The web-based location may seem of great benefit, but not everyone has access to the internet, nor are they technically savvy. This would be a barrier for that population. Unless the iPrevent leads the user to the IBIS, it does not include any lifestyle choice questions. After learning about several risk management tools that are utilized, which risk management tool would you use to assess this patient's lifetime risk of breast cancer? Did your choice change from earlier in the presentation? If so, why did it change? This next section discusses screening recommendations. Screening is used to detect breast cancer as well as precancerous breast conditions at the earliest and most treatable stages. Screening guidelines are developed using data collected from clinical research and cancer registry databases. Routine screening is the primary method to detect cancer in its earliest stages before symptoms develop. Screening is the only imaging modality proven to significantly lower BCA mortality. Screening also includes imaging, a physical examination, and a self-examination. Imaging modalities can include sonography, mammography, magnetic resonance imaging, and most recently, tomosynthesis and contrast-enhanced mammography. There are 3 organizations that have screening guidelines for breast cancer: the American Cancer Society, the U.S. Preventative Services Task Force, and the National Comprehensive Cancer Network. The main difference between the guidelines for all 3 organizations include age at which women should start and stop screening, the frequency of screening, and the type of screening modalities recommended. These variations are related to long-standing controversies about breast cancer screening and the data for each organization to develop these guidelines. Guidelines vary depending on whether the patient is of average or elevated risk for breast cancer. Women at average risk have no personal or family history of breast cancer, no genetic susceptibility, and no history of chest radiation treatments. Women considered to be of moderate risk are when their lifetime risk score is 15 to 20%, and are considered to be of high risk when their lifetime risk score is 20% or higher. ACS breast cancer recommendations are categorized by age and risk. ACS recommends that women at average risk begin regular screening mammography at age 45, with the opportunity to begin annual screening at the age of 40. Qualified recommendations include annual screening for women 45 to 54 and biennial or annual screening at 55 and older. The ACS recommends yearly mammography for patients at high risk for breast cancer starting at age 30. The U.S. Preventative Service Task Force made evidence-based recommendations about clinical preventative services, counseling services, and medications. The USPSTF examined trial evidence on how frequently to screen women ages 40 to 45, and none of the trials specifically noted greater benefit of the annual mammography in a specific interval. The USPSTF concluded that the biannual mammography screening is appropriate for women aged 50 to 74. For high-risk women, they recommend screening yearly starting at the age of 30 with an MRI. Of note, USPSTF does not include specific high-risk screening criteria, but notes that women ages 40 to 49 who have a first-degree relative with a history of breast cancer may benefit more than the average risk woman of the same age if screened before 50. The NCCN was created in 1995 to develop and institute the standards of care to help healthcare professionals diagnose and treat people with cancer. According to the NCCN guidelines, they recommend women of average risk to begin screening mammography at age 40, then annually every year until the age of 75. After 75, it is based on the clinical judgment of the primary care provider or cancer specialist. High-risk women are recommended to have yearly mammograms with an MRI starting as early as age 30. So back to the case study. Recall that this patient presented with an incidental finding of lump on exam. Regardless of whether the lump is an incidental finding manually or found on routine screening, the psychosocial needs are familiar. After seeing the risk factors, risk assessment tools, and screening recommendations, it's important to keep the psychosocial needs of the patient in mind. So, during this visit, did you identify any new or different psychosocial needs for the patient when she presented at the clinic for her initial visit, as you discussed risk factors and screening recommendations? If so, what are they? This section discusses diagnostic recommendations and guidelines. Mammography is the most commonly screening tool used worldwide for the detection of early breast cancer in asymptomatic women. Some disadvantages include lower specificity and sensitivity in diagnosing malignant breast lesions. Sensitivity refers to the ability of a test to correctly identify those with the disease, and specificity refers to the ability of a test to correctly identify those without the disease. Sonography is the preferred diagnostic modality for palpable masses. The ACS does not recommend ultrasound use instead of mammography for screening purposes and is a very limited tool. Ultrasound can be useful when screening high-risk patients who can't have an MRI due to a pacemaker, and also for distinguishing cysts form like masses. The MRI has several advantages. It is a useful tool for detection and characterization of breast disease, assessment of the local extent of the disease, evaluation of treatment response, and guidance for biopsy and localization. MRI benefits with diagnosing breast cancer, including the lack of ionizing radiation, better 3D spatial resolution, better ability to delineate the true size of the cancer, as well as the ability to image both breasts and the chest wall. MRIs are the best method for determining pectoralis muscle and chest wall involvement. The disadvantages to having an MRI can include expense, requiring the use of intravenous contrast, limited use in patients who can't lie prone or are obese, have extremely large breasts, or are claustrophobic. Patients have to be screened as well for contraindications to the MRI. Breast MRI have more false positive results than mammography. A false positive result incorrectly reports a woman with breast cancer when they actually do not have breast cancer. If possible, women should be scheduled for a breast MRI during the second week of their menstrual cycle to minimize background enhancement. A core biopsy is the standard method and the only test that can diagnose breast cancer. A biopsy removes cells or tissues from the suspicious areas of the breast. These cells or tissues are studied under a microscope to see if there are cancer cells present. There are two approaches to this biopsy: the needle biopsy and the surgical biopsy. The needle biopsy removes tissue or cells with a needle only, where the surgical biopsy involves a surgeon that makes a cut into the breast and removes the tissue or lump. Both patients as well as their partners experience significant distress after a breast cancer diagnosis. It has been found that partners or family are equally likely to feel unsupported by their patient and can feel down or depressed. Based on the Institute of Medicine report in 2007, there is a mandate to meet the psychosocial needs of patients and their families with a cancer diagnosis. A multidisciplinary approach can be established with these patients that include the patient, oncologist, primary physician, nurse, social worker, and psychologist if possible. Some agencies even have distress screening tools that confirm the presence of physical, behavioral, social, spiritual, and financial support needs to identify appropriate referrals needed for the patient and their loved ones.
Other psychosocial needs for the breast cancer patients can include getting informational support. Patients need to learn about breast cancer in a layman's term. The more understanding the patient has about their diagnosis, the more they are aware of all treatment options available. Providing information to loved ones about the diagnosis or having someone in their support system attend appointments can be beneficial for learning what the next step in treatment can be. Emotional support. A wide range of emotions come with a diagnosis of breast cancer, such as fear, shock, denial, or sadness. Having someone there to listen in order to express their personal feelings about the diagnosis is key. Even hugs from family members or friends can be helpful. Having practical support. This support could include offerings to help the patient with any cleaning, housework, transportation to and from appointments, laundry, watching their children, or even calling them to find out what their needs are. Based on new knowledge, what screening and diagnostic approaches would you use for this patient? This section will explain the recommended treatments for breast cancer.
When patients are diagnosed with breast cancer, some patients immediately say, well, just chop them off. It is not that simple. There are some general guidelines as to when a lumpectomy can and should be done versus when a mastectomy should be done. A lumpectomy is a surgical procedure done to remove the tumor from the breast. A small amount of the surrounding healthy tissue is also removed for safety measures. If diagnosed early, many women with breast cancer may be given the choice between a lumpectomy or a mastectomy. Although a lumpectomy leaves the woman with her own breast tissue, they may require radiation as part of their breast cancer treatment. Some women may opt to have a mastectomy instead of a lumpectomy, thinking it decreases their risk of reoccurrence of the cancer. But studies have shown that having a mastectomy instead of a lumpectomy does not increase their chances of survival rate, or provide better treatment outcomes. There is a higher chance of local reoccurrence of breast cancer when a lumpectomy is done without radiation. A mastectomy is an invasive surgical procedure done to remove breast tissue. Mastectomies may require further surgical procedures if the patient decides to have their own breasts reconstructed. There are several types of mastectomies. A simple mastectomy is done in which the surgeon removes the entire breast, including the nipple, areola, skin, and possibly axillary lymph nodes. A skin-sparing mastectomy is one in which the skin of the breast is left intact, but the breast tissue, the nipple, and the areola are removed. Breast implants are then used to replace the removed tissue and offers an immediate reconstruction option. A nipple-sparing mastectomy is similar to a skin-sparing mastectomy, but only the breast tissue is removed and the nipple and areola are left with the breast skin. Breast implants can be used for reconstruction immediately. This type of mastectomy may not be a good option if the cancer is near the nipple or areola or in big-breasted women. Cancerous cells can remain in the nipple or areola and may put women at higher risk of reoccurrence if not caught. Some surgeons choose to radiate the nipple and areola during surgery to reduce the risk of cancerous cells being left behind. Other complications from this type of mastectomy include the nipple or areola looking deformed or shrinking due to the lack of blood supply, or looking out of place after the implants are used. A modified radical mastectomy is a simple mastectomy but includes removal of the axillary nodes as well. Radical mastectomies are not done as often now, but are still done if a large tumor is growing into the chest wall. A radical mastectomy is removal of the entire breast, axillary lymph nodes, and the pectoral muscles. Modified radical mastectomies have been found to be just as effective as radical mastectomies and have fewer side effects. Unilateral mastectomies are done to remove the breast tissue of one breast after cancerous cells have spread beyond the local tissue surrounding a cancerous tumor. Unless cancerous cells have been found bilaterally, there is not usually any reason to remove both breasts. A double mastectomy is often done as a risk reduction surgery for patients who are at an elevated lifetime risk of breast cancer, such as those with the BRCA gene. Most of the time, these are simple mastectomies. Reconstructive surgery is not mandatory. It is a patient preference. Reconstructive breast surgery is not necessary and does not have to be done at the time of the mastectomy, but the outcomes may be better if they are done at the same time. When considering reconstructive surgery, several variables need to be considered, including the overall health of the patient, history of smoking status, underlying disease like hypertension or clotting disorders, the size of the breasts, the location and size of the tumor, the extent of the surgery, such as simple mastectomy versus radical mastectomy, the amount of tissue available, insurance coverage, recovery times, and if any other treatments are still needed, such as chemotherapy or radiation. There are two main types of reconstructive breast surgery. A patient can have silicone implants and use their own tissue to cover them. They can also have breasts reconstructed using their own tissue from varying areas of their body, such as their abdomen, inner thigh, back, or buttock. This is called a tissue flap procedure. Tissue flap procedures tend to look more natural since the breasts are reconstructed from the patient's very own tissues. They may even grow or shrink as the patient gains or loses weight, like natural breasts would do. Tissue flap procedures are not a recommended option for smokers, uncontrolled diabetics, women with connective tissue diseases, and women with vascular disease because the tissue needs adequate circulation to heal properly. Surgery may also not be an option for patients if they are too thin and do not have enough tissue for reconstruction, or if they are too obese. If the patient is unable to undergo breast reconstruction surgery, they can look into a breast prosthetic. This is also called a bra implant. The last option is to go flat. Prostheses can be worn inside the bra in special pockets, or they can be worn inside a normal bra. Chemotherapy may not be used to treat all breast cancers. In fact, some types of breast cancer are treated by doing a lumpectomy along with radiation therapy. When chemotherapy is needed, it is often used in one of three ways. Neoadjuvant chemotherapy is used with the goal of shrinking tumors prior to surgery. Adjuvant chemotherapy is used with the goal of killing cancer cells that may have been left behind but cannot be seen on scans. In patients with advanced breast cancer, chemotherapy is used as the main treatment when the cancer cells have metastasized beyond the breast and axillary lymph nodes. There are gene expression tests that can be done to see whether a woman would benefit from chemotherapy or a mastectomy. Chemotherapy is often very effective when done as a combination drug therapy, usually consisting of 2 to 3 chemotherapy drugs. Common chemotherapy drugs used in neoadjuvant and adjuvant therapy include Elents, adriamycin, Taxol, Taxotere, 5-FU, cytotoxin, and periplatin. Chemotherapy used to treat advanced breast cancer is often administered as a single chemotherapy agent. Some of these agents include Taxol, Abraxane, anthracyclines, platinum agents, vinorelbine, Xeloda, Gemzar, and Halaven, just to name a few. Most patients have a port placed prior to receiving chemotherapy. Chemotherapy can cause a lot of side effects, so it is important to understand what they are so you are able to properly educate patients. Common side effects of chemotherapy include hair loss, sores in the mouth, weight loss, nausea, vomiting, diarrhea, nail changes, increased risk of infections from neutropenia, bruising, and fatigue. Chemotherapy can also cause issues with fertility, menstrual cycles, neuropathy, heart and lung damage, and some can even increase the risk of leukemia. Radiation therapy is made up of high-energy rays that destroy cancer cells. Radiation is done in combination with other treatments such as surgery and/or chemotherapy. It is dependent upon the type of patient's cancer and the size of the tumor. There are 2 types of radiation that may be used. External beam radiation is administered from a machine and outside of the body. Internal radiation is administered when a radioactive source is placed inside the body for a short period of time. Radiation therapy is used as a treatment depending upon the type of breast cancer, the type of treatment you are receiving, if the cancer has metastasized, and tumor size. Common side effects of external beam radiation while receiving treatment include swelling of the breast, skin changes such as redness or peeling skin at the site of the treatment, and fatigue. External beam radiation can have long-term side effects, and those include difficulties breastfeeding, firm breasts, shrinkage of breast tissue, brachial plexopathy, lymphedema, angiosarcoma, and weak rib bones. Common side effects of internal radiation include redness at insertion site, bruising at the insertion site, seroma, breast pain, damage to the fatty tissue of the breast, and infection in the breast at the insertion site. Rib fractures and weakness are also possible side effects of internal radiation. While there are more cosmetic side effects with internal radiation, it has been shown to have equal cancer control to external radiation.
Patients with cancer oftentimes have many psychosocial needs that go unmet. Many patients do not voluntarily express their needs or concerns with their families or healthcare team. Many patients may feel like suffering is inevitable when you have cancer, or like there is no treatment for the symptoms they are feeling, so they don't voice their concerns or ask for help. Routine screening of patients' psychosocial needs is a recommended practice that has been found to help pick up on needs of the patient that is otherwise may go unmet or unnoticed. Treatment of breast cancer brings on a whole new set of psychosocial issues for women with breast cancer. Many women suffer from anxiety, depression, and grief as they go through treatment and any surgical processes that may affect the cosmetic appearance of their body. Social support such as church groups, counseling, cancer support groups, friends, family, or religious groups may provide much needed psychosocial and emotional support to breast cancer patients going through treatment and survivors as they struggle with the many changes having breast cancer. Many women, especially if younger, may worry about how breast cancer will affect their ability to have babies and breastfeed. Women may also worry about the changes in their menstruation cycle, possibly leading to menopause. Sexuality is another thing many women are concerned about after breast cancer treatment, especially if their treatment altered how their body looks. Some women worry about being attractive to their significant other, and it can cause significant emotional distress. Offering information on support services to patients and encouraging them to use social services available to them through their oncologist or local hospital may help them to utilize resources they may not have known about otherwise.
This next section discusses practical implications, both individual and population based. Primary prevention begins by maintaining a healthy lifestyle, eating a healthy diet, and avoiding excessive alcohol and tobacco use. Breast cancer screening is effective only when it accompanies close follow-up and prompt evaluation with an abnormal screening exam. The American Cancer Society of Clinical Oncology recommends routine history taking, physical examination, and mammography in order to diagnose breast cancer. There are significant barriers that could occur and will need to be addressed in practice for the individual breast cancer patient. Barriers include miscommunication due to cultural or language issues, cultural stigma or beliefs about cancer screenings in general, fear of pain, discomfort, or embarrassment when having screening done, lack of financial resources to pay for screening or follow-up care, no support from family to get further screening. Being aware of the different cultural practices for an individual is key to compliance and ensures follow-up when necessary. Two cultures have been found to have higher mortality rates of breast cancer deaths and practical implications. These populations will be discussed further in the next few slides. Culturally tailored interventions are needed to address cancer-related disparities among diverse populations. Breast cancer is the most commonly diagnosed and leading cause of death among Hispanic women alone. Hispanic women have shown to have greater social, psychological, and physical needs. There is a need for promoting the importance of routine clinical breast examination, annual mammograms, and performing monthly self-breast exams to this population. But there are barriers for this population that prevent Hispanics from receiving adequate screening as well as close follow-up. These barriers include lack of access to adequate care, language barriers, lack of insurance, lack of understanding of treatment options, lack of transportation, fear of deportation, and lack of having a medical provider. Nurses need to be aware of these barriers and be able to provide mental and emotional health counseling to address depression, anxiety, or distress. When psychological symptoms are untreated, this can have a direct effect on the individual's quality of life. Information on survivorship care planning and self-care management will need to be addressed with the patient and their support system. An interpreter should be provided at each appointment to help explain the screening and other tests, as well as the treatment plan for this population, so they have a better understanding of their diagnosis. Usage of patient navigators can be effective because they can be used to help promote certain behaviors such as patient adherence, as well as reduce barriers to care. Education of this population about how important early screening is for a definitive diagnosis can help with detection of breast cancer and decrease mortality rates. The African American population is also at high risk for breast cancer. African American women have been identified as having an increased prevalence at a younger age and an increased mortality rate from breast cancer. Breast cancer tends to be more aggressive and to be an advanced disease at diagnosis in the African American population. African American females have reported the following barriers: issues of distrust in the medical community, lack of privacy with examination, as well as how the patient-provider relationship felt impersonal when given the news from the provider about their breast cancer diagnosis. In 2015, Jones also noted the following barriers: knowledge deficit of how to perform self-breast exams, when to follow up for their breast cancer screening, and lack of knowledge treatment options. It was felt that medical professionals should discuss the best possible treatment in regard to their stage, type of breast cancer, age, preference, risks, and benefits. The American Cancer Guidelines strongly recommend that each healthcare provider discuss the benefits and limitations of screening tools, mammography, and clinical examination. The ACS also recommends that providers should obtain an MRI to detect breast cancer for the African American women who are at higher risk for this condition. With concern for the African American community, nurses, as well as physicians, should reflect on their own values and beliefs in regard to sexism, racism, ageism, and tolerance to others. Genetic testing should be offered to this population to identify any genetic mutations with hereditary links in their family. Knowing about spirituality, this population's faith in prayer, and how it plays an important role in the healing process is necessary. Having a social support system in this population is essential to help families and the patient cope with the disease. This population has been shown to have the highest rates of uninsured and underinsured individuals among minorities, which is linked to the lack of access to preventative care services, including breast cancer screenings and mammography. These are just a few social determinants with this population. Bottom line, if these guidelines are applied to everyone without exception of race or diversity, the screening of cancer would be effective in identifying individuals at the earliest stage of breast cancer possible and would help to reduce mortality rates.
So, in summary, care providers need to familiarize themselves with etiology and risk factors outside of the genetic variables. This is a benefit when teaching patients about all the risk factors and which ones they can modify to decrease their individual risk. Care providers should become aware of and familiar with the different risk assessment tools available. It's important to utilize the most appropriate tool for the individual patient. This will help in developing the individualized screening and diagnostic plan for each patient. One size does not fit all. When reviewing practical implications, it's important to become familiar with evidence-based guidelines for routine screening. The American Cancer Society of Oncology provides updated recommendations and can be utilized as a reputable resource in practice. Review of potential barriers for the individual patient is a necessity to help ensure compliance. Some questions the provider should ponder. Is there a potential for miscommunication due to cultural or language issues? Does the individual's culture hold stigmas or beliefs regarding cancer or cancer screenings in general? Does the patient seem fearful? Is the fear related to concerns of pain or discomfort? Is the patient embarrassed about having to be naked from the waist up or having breasts exposed or manipulated? What is the patient's insurance status? Is there a lack of financial resources to pay for screening or follow up care? Does the patient have a support system in place to help them cope with potential positive findings? Some of these previous questions can also be included in population based practical implications. There are cultures that have a history of barriers related to language, lack of insurance, fear of deportation, cultural, religious, and spiritual beliefs regarding medical care and or cancer, lack of knowledge for reasons behind screenings, lack of social support, lack of transportation, and lack of knowledge related to how screening and early diagnosis increases survival rates. This concludes our presentation. We hope the information that we have provided regarding breast cancer risk factors, screening, diagnosis, and treatment guidelines have provided you with updated information. We also hope it is beneficial when taking practical implications and social needs into consideration as you plan with patient care. Thank you.